Cool. So no guarantees that this is even going to work. So we'll give it a go. And
Sure, especially the audio. Just let me know if the audio is good. I have headphones, but they're as nerdy as a radiologist is supposed to be. So I don't know if that's on message or not.
Thank you so much for coming. Do you mind just introducing yourself real quick?
Sure. I'm Evan Lieberman. I'm a PGY5 radiology resident at Maimonides.
Thanks for coming, Evan. Appreciate it. Just a couple really pointed questions for this session. I wanted to ask you about two radiology studies that we order a lot from the emergency department. And the first one I just wanted to talk about was a PE study. So I feel like I get my clinical suspicion. I consider this patient high risk for pulmonary embolism. I click some buttons on the computer. They disappear behind the double doors for, 10 minutes or so and come back, and I have a study. Just wondering, can you give me sort of an idea of what goes on behind the curtain when I'm actually ordering a PE study for a patient?
Sure. So actually, I pulled up a scan here. I can show you sort of step-by-step what we do and sort of give you a little micro tutorial what we see and what you guys might see when you look at the pictures. So here's a patient actually from last night from the ER. There's no names here. And so essentially, the patient goes through the machine, and we do what's called scout, where the patient doesn't move. The scanner just kind of scans over the patient. We outline the patient. We estimate where we think the pulmonary artery is going to be, somewhere over here. So then we pick a slice. And what we do is we draw what's called an ROI. That's this circle over here. And the computer is going to measure automatically the Hounsfield units. I don't know how well you can see that. And so basically what it's going to do is we're going to inject contrast through the IV, and then it's going to keep scanning every couple seconds until it hits a certain number of Hounsfield units. And that's going to trigger it to automatically scan the whole chest, because it's going to measure and say, okay, in 5 seconds when the scan starts, we're going to have enough contrast in the artery to make sure that we can tell is there or isn't a thrombus there. And so what happens is that, as you can see, it keeps scanning. Now, of course, in this patient, he was moving around a lot. So the circle stays put, but it's jumping around all over the place. And so as you can see, it's hard to tell. The computer might get confused as to when is it getting in the pulmonary artery, or is it hitting the aorta? Is it hitting the bone? Is it hitting the lung? It's a lot of things that can go wrong here because it is a tight area. And so, of course, our initial scan was non-diagnostic. We got no contrast in the patient because he was jumping around and didn't measure it. But we were able to do it again, scan him again. So now you can see the pulmonary artery is nice and bright, really white, which is what we want to see, because a thrombus is going to be dark. So basically, we're trying to outline everything that isn't a thrombus and really take a look. And really, it's most important when we get down to the small vessels, because you can see they disappear really fast. And so if they're not really, really bright, we're going to have a hard time figuring out, is there a small PE there, or is this a pulmonary artery or vein or something else? And that's part of the reason why we give a lot of contrast really fast, because we ideally only want to have contrast in the pulmonary artery. We don't want to have them in the veins, and we don't want to have them in the aorta, so that when we get down to these small vessels, we can tell really easily what's a pulmonary artery and what's not, because oftentimes something can look like a thrombus, but it's not actually the pulmonary artery.
You mentioned a couple times there that you want really good flow through a good IV. I feel like the textbook answer for this is put an 18 gauge in the AC and we're good to go. But a lot of times our nurses aren't able to get an 18 gauge in the AC. Sometimes we have a 20, sometimes we have a 20 in the hand.
Basically, when we're doing a PE study in particular, or other kinds of angiographic studies in the chest, we're giving 4 or even sometimes more cc's per second through this IV for maybe 100 cc's of contrast. So that's a lot of contrast very quickly for a very sustained period of time. Unlike most medications, which are given even as a bolus, it's not that much volume and it's not that fast. We're giving the amounts that you guys might give, over the course of an hour. We're giving it in less than a minute. But the key thing is really the feel. If you have a good IV that you can take that syringe with the flush and flush it hard, and you can get that whole syringe in less than a second and feel good and not worry that it's going to blow, you're probably going to be okay. And everyone's a little different. Some people have big veins, some people have small veins, some people have a lot of collaterals, some people have good flow, bad flow, so it's really a lot of factors, but almost always if you have an 18 in the AC, you're pretty much guaranteed to be good to go.
All right, I'm gonna try and pin you down now. I get that it's a feel thing. I've got an 18 in the hand, and it's a big bore, flushes really nicely, but it's in the hand. Are you gonna scan that patient?
Maybe. I mean, we're going to really check it. Now, I'm probably going to get a phone call as the radiologist from the tech to be like, hey, listen, I'm not sure what you want to do, because I've seen cases where even big people with big hands, it just doesn't go right because it feels nice, but the what happens is it may work for a small amount, but by the time you give them that whole contrast, it just doesn't get all the way to the heart the way you want to. So that vein holds it in the forearm, but it doesn't actually go well continuously up into the chest. And so it never really gets there and maintains that nice bolus in the chest. That's why we know when we're proximal, we're guaranteed to get that big vein and not have just one little vein that gets a little big in the hand and then they're tiny in the forearm. And you never know that because under normal circumstances, it goes just fine. Look, the other thing is if it's really that tenuous, then you have to consider putting a central line or doing some other kind of midline, something a little bit more substantial that's more reliable. If we have a central line, we can use that. Patients who you guys really think have an acute PE or acute dissection, those patients are pretty sick for the most part. And so you might even consider doing that irrespective of their need for, for a PE study or some other kind of CT. So if you're going to think about that, we might say, listen, get it done, get them secured, make sure they're stable. Because if they're that unstable, you want to have your access. You don't want to lose that. It's bad for the patient. We don't want crashing on the CAT scan table. It can happen.
I think that's a really great transition into the next imaging choice that I wanted to ask you about, which was dissection studies. So, I mean, when we talk about PE studies, the way you just kind of walked me through it, we put the patient on the table, we take a couple scans, we wait for the contrast to get there, and then we just scan through the pulmonary arterial system. Is it sort of the same idea for an aorta study?
So it's similar in a lot of ways, but there are some very key differences. So number one is we're looking at not just the chest when we do a dissection, we're going to look at the whole chest, abdomen, pelvis. We're going to look at the whole aorta at the end of the day. And so we need to give more contrast to fill the entire aorta at the right amount of time. And the second thing to remember is that the heart beats. And so we need to get rid of that heartbeat because we need to look at the root, the aortic root, very carefully. Because that's the main area where the type A dissections that need to go to the OR, that's what we need to know. Is it a type A dissection or not? Sometimes they're very small. We really have to make sure that we get that right. And so what we do is we attach EKG leads to the patient and it's hooked up to the CT scanner. And we use what's called ECG gating. And so basically the computer will synchronize with the heartbeat when they scan the patient. And so in the ER setting, they're going to scan the patient throughout the cardiac cycle and then reconstruct the heart in such a way where it looks like it's not moving. We're going to do actually 3 scans through the chest on a dissection study. So first, we're going to do a non-contrast scan with gating to make sure we look at the root to look for what's called an intramural hematoma. So that can be a type of type A dissection that might be obscured by contrast. Then we do a second pass in that early arterial phase, make sure that heart and the aorta is nice and bright so we can see, again, is there anything leaking out or is there a flap? And then we're going to do a quick scan afterwards of the chest, abdomen, and pelvis to look for any of the other complications that come from a dissection, like taking off the visceral vessels or any other things where the hematoma is expanding or bleeding out into the chest or making a fistula or doing something else like that. So the dissection study is a lot more radiation, a lot more scans, a lot more imaging, and potentially a lot more contrast depending on the size of the patient because it's based on the patient's weight.
That third scan through that you do, is that the equivalent of my regular IV contrast chest abdo pelvis, or is that sort of like different phase still?
So it's different, right? So it's different in 2 major ways. Number one is it's done right after that initial aorta pass. So it's very early. It's still looking at the aorta. We're just getting it a little later than when the first contrast gets there. We're not waiting till it gets all the way into the portal venous system and it opacifies all the organs really well. So the organs are going to look a little funny. They're not going to look normal. I mean, we can see big problems, but usually you're trying to figure out, like, is the kidney infarcted or is there flow, to the SMA or whatever it may be. So that's what we're looking at, really the proximal arteries. And the second thing is the dose is lower. Because we're scanning faster, we're not trying to look at every little thing, look for tiny nodules and look for little things. We're trying to lower the radiation dose considering how much we've already given the patient and the fact that the contrast is not going to be at that optimal phase. We're really trying to just look for, is there any obvious organ damage? Is there an obvious flap that's taking off a vessel that the surgeon has to know about before moving forward?
So there's a reason I wanted to ask about these two imaging choices together during the same chat, and that's because it is not infrequent where we want to be able to do both of these studies in one patient. So, I was talking to you earlier, the 60-year-old man who's got ripping chest pain going to his back. He's a little hypertensive. He's in the 150s, 160s systolic, but he's also I'm also having some shortness of breath. And we put him on the monitor. His saturation's 91%. We do our exam and we're like, oh, your legs are swollen. He goes, oh yeah, that's similar to when I had my DVT, 10 years ago. And suddenly I'm like, oh no, this guy needs a dissection study, but he also needs a PE study. Can I get both?
Probably. but it's hard to guarantee that. And so part of the problem is, like I showed you, when we draw that circle, we can only really draw one circle. And so what happens is that we have to pick where we put the circle. And so what happens is that for the PE study, the PE is earlier in the phase because the contrast gets to the pulmonary artery before it gets to the rest of the heart. And so we're not going to get a dissection study at all, basically, with that kind of imaging, because it's always going to be too early. We're never going to really have opacified the aorta. But the opposite is not necessarily true, right? Because if we image the aorta, we may still have a lot of contrast, especially if we're still injecting into the pulmonary artery. So a lot of our dissection studies, almost by accident, have enough contrast in the pulmonary artery to see them, but there's no guarantee that we're going to get that. If you really have a concern, what we can do is basically just keep injecting the contrast. And so what happens is that by the time the aorta fills with enough contrast, we're sort of continuing to fill on the backside. And so the pulmonary artery will likely still maintain its opacification. Most of our dissection studies are going to show the PE, at least to some degree, at least the main vessels. And the truth is that as far as acute emergencies are concerned, the dissection is really going to be more of an acute go, no go, OR, not OR, treatment issue. The PE study, you can decide whether you want to anticoagulate or not, depending on what the dissection shows, and sort of decide to rescan later if you really have to, or do some other kind of evaluation. So I would say in that situation, go with the dissection because that's the more critical issue, and you probably will get your information. But if you're not sure, call the radiologist. They'll try to maybe modify the study to increase the chances that your PE study is going to be good.
So don't just straight up order an aorta study. I should call my radiologist and say, hey, I'm interested in looking at the aorta, but PE is also on the differential for this patient.
Right. And the other thing is that even if we do the study the same way, we definitely want to know what you're thinking so we know to look for that extra carefully. Because sometimes we'll look at it quickly, but we won't really scrutinize it the same way we do a PE because we're looking at dissection, we're looking for the 100 other things that go along with dissection. But if you really are concerned about PE, we want to know that because we want to make sure that we're not missing something or having any question that we might pass. We want to make sure, hey, listen, I think there's this, I think there's that, let's have that conversation or let's work it together and make sure. And if not, I can always make sure the tech watches it out for it and says, hey, listen, give me a little extra contrast, do a little extra to try and make sure that that works.
Evan, thank you for entertaining all of my questions. I appreciate your expertise and your willingness to teach and talk with me. Thanks so much, man.
Happy to do so anytime.